Hi, everyone, and welcome to the breast cancer webinar. My name is Neelam Patel. I'm a clinical pharmacy specialist at the University of Texas MD Anderson Cancer Center in Houston, and I will be going over breast cancer with you today. I'd like to tell you that I have no disclosures. And the objectives of this presentation are to identify risk factors, staging, and prognosis of breast cancer, recognize the therapeutic targets for breast cancer based on different types of testing, choosing an individualized therapeutic plan based on the assessment of patient information, available evidence, and treatment guidelines for the management of breast cancer, and lastly, to be able to modify treatment plans based on patient-specific characteristics and toxicities due to treatment of breast cancer. The overall goal is to give a high-level overview of the treatment of breast cancer. So let's get started. Breast cancer is the most commonly diagnosed cancer worldwide. Approximately 270,000 cases were diagnosed in 2019 in women, and these are invasive breast cancer cases. There were approximately 2,700 cases of invasive breast cancer diagnosed in men. And breast cancer is the second leading cause of cancer-related death among women, behind lung cancer. The table here outlines roughly the approximate prevalence of the different subtypes of breast cancer. And so the most common subtype is hormone receptor positive, HER2 negative breast cancer, which accounts for about 70% of all invasive breast cancers, followed by HER2 negative or HER2, hormone receptor negative or hormone receptor positive breast cancer that is either HER2 negative or HER2 positive. And lastly, hormone receptor negative breast cancer that is also HER2 positive, which accounts for about 5% of all breast cancer cases. I'll ask you to refer to the Fundamentals podcast for further information on epidemiology, molecular subtypes, risk factors, survival, and staging. And so we'll jump right into treatment. So I'll start with the different treatment modalities that are available based on the stage of breast cancer that's diagnosed. Stage 0 breast cancer is a DCIS, or ductal carcinoma in situ, and the possible treatment modalities for this include surgery, radiation, and adjuvant endocrine therapy if the DCIS is hormone receptor positive, in which most cases it is. And the goal here is to prevent invasive breast cancer. So stage 0 breast cancer is in a category on its own, and it's considered a non-invasive breast cancer. So as we talk about the treatment of breast cancer, we'll be focusing more on stage 1 through 3, as well as stage 4 or metastatic breast cancer. So you'll see the common modality of treatment for stage 1 through 3 is surgery. Surgery still remains primary treatment for early stage breast cancer. Radiation therapy is a possible treatment modality based on the staging of the cancer and also based on the type of surgery that the patient undergoes, a lumpectomy or a mastectomy. More details on that are provided in the breast cancer outline. And then chemotherapy, biotherapy, and endocrine therapy are all based upon staging and prognosis, as well as hormone receptor status and HER2 status. The goals of therapy for all stage 1 through 3 breast cancer is cure and prevention of disease recurrence. Lastly, with stage 4 breast cancer or metastatic breast cancer, possible treatment modalities, generally speaking, include chemotherapy, biotherapy, and endocrine therapy. Surgery and or radiation therapy may be considered in some patients, depending on symptoms, like palliation of symptoms, if that's needed. But in large, surgery is not usually a part of the treatment modality for stage 4 breast cancer. And the goal of therapy here too changes. The goal generally becomes disease control and palliation of any symptoms that may be present, and as well as life prolongation. This slide and the next 4 slides that follow provide an overview of recommendations for adjuvant systemic therapy based on hormone receptor status and HER2 status, as well as node positivity or extent of disease. So these 5 slides actually do a really good job of guiding, from a high-level overview, guiding what the steps would be based on the staging of breast cancer of the patient. So this first slide focuses specifically on hormone receptor positive, HER2 negative, node negative breast cancer. And the division is between a tumor size less than or equal to 1/2 centimeter compared to greater than 1/2 centimeter. So in your really small tumors with node negativity, adjuvant endocrine therapy is recommended to be considered. In tumors that are larger, the recommendation per NCCN guidelines for breast cancer is to consider a 21 gene assay. Depending on the results of the assay, the following recommendations are outlined. So if it is very clear that if a recurrence score of on this assay is greater than or equal to 31, adjuvant chemotherapy is recommended, followed by adjuvant endocrine therapy. If the recurrence score is less than 26, adjuvant endocrine therapy alone is recommended. And for the recurrence score between 26 and 30, adjuvant endocrine therapy or adjuvant chemotherapy followed by endocrine therapy is recommended. And that is when other patient-specific risk factors may be taken into consideration to make that decision. Next, we'll go over hormone receptor positive, HER2 negative, node positive disease. If a patient has pathologic N1-MI or N1 disease, which is less than 4 nodes, the recommendation is to make a decision for adjuvant chemotherapy based on clinical characteristics, tumor stage, and pathology. Based on this information, the patient should be evaluated to see whether or not they're a candidate for chemotherapy in general. If the patient is deemed a candidate for chemotherapy and they can consider undergoing a multi-gene assay to assess prognosis and chemotherapy benefit. And at that point, a decision will be made based on the score. If a patient is deemed a candidate for chemotherapy, but the assay is not available or is not done, the recommendation is to use clinical and pathologic features for making these decisions. And in that case, chemotherapy, adjuvant chemotherapy followed by endocrine therapy is recommended. I'd like to point out here too that the asterisk indicates a category 1 recommendation. And in these patients who are not candidates for chemotherapy, adjuvant endocrine therapy is recommended. For patients who have node positive breast cancer, which is in this case considered to be greater than or equal to 4 ipsilateral nodal metastases, the recommendation is to offer adjuvant chemotherapy followed by endocrine therapy. In our hormone receptor positive, HER2 positive patients who have breast cancer, the recommendation for chemotherapy and or biotherapy followed by endocrine therapy is dependent on, again, on the size of the tumor and the status of node positivity or negativity. So this here is broken down a little bit more than in the types that I discussed before. So the smaller the tumor, the less likely or the less strong the recommendation to have the patient undergo chemotherapy with trastuzumab, followed by endocrine therapy. And then the larger the tumor, the stronger the recommendation is for adjuvant chemotherapy with trastuzumab followed by endocrine therapy. If a patient does have node positive disease, again here, in this case, the recommendation is to offer adjuvant chemotherapy with trastuzumab plus or minus pertuzumab followed by endocrine therapy. You can see that the common theme here is that node positivity generally means that chemotherapy plus or minus biotherapy will be offered in the adjuvant setting. In hormone receptor negative, HER2 positive breast cancer, the breakdown is similar, except that there is no endocrine therapy offered because these patients have hormone receptor negative breast cancer. And so outside of that, the recommendations remain the same. And then lastly, we have hormone receptor negative, HER2 negative breast cancer. And here too, the treatment recommendations are divided up first based on tumor size and then node negativity or positivity. And in this case, the small tumors less than or equal to 0.5 centimeter and node negative, no adjuvant therapy is recommended. If someone has a PN1-MI or micrometastases, the recommendation is to consider adjuvant chemotherapy. If patients have a tumor that's between 0.6 and 1 centimeter, the recommendation is to consider chemotherapy. Often in clinical practice, depending on other patient characteristics, the consider may be more of a there may be more of a push to actually offer adjuvant chemotherapy. And tumors greater than 1 centimeter in the ER/PR negative, HER2 negative population, adjuvant chemotherapy is recommended as a category 1 recommendation. And again, if there are positive nodes in these patients, and that actually equates to 1 or more ipsilateral nodal metastases, adjuvant chemotherapy is definitely recommended.
This slide shows treatment options for early stage breast cancer treatment with regards to chemotherapy, and this is specifically for HER2 negative breast cancer. The NCCN guidelines do indicate that these regimens may be used in the neoadjuvant or adjuvant setting as indicated by the asterisk on the table. The regimens that are in bold are currently listed as preferred per the breast cancer NCCN guidelines. This table shows chemotherapy regimen options for HER2 positive breast cancer in the early stage setting. The regimens that are in bold are indicated as preferred by the NCCN. And I'd also like to point out here that these regimens can also be used in the neoadjuvant or adjuvant setting per the NCCN guidelines. One of the biggest differences in treatment of HER2 positive breast cancer in the curative setting in recent years is the change in adjuvant therapy with an anti-HER2 agent. For years, we've been using 1 year of trastuzumab plus or minus pertuzumab to complete the 1 year of therapy, but based on the Catherine study, the recommendation is now that if there is residual disease at time of surgery after neoadjuvant chemotherapy has been completed, the recommendation is to complete the year of anti-HER2 therapy with adotrastuzumab emtansine versus just using trastuzumab plus or minus pertuzumab. If there is no residual disease after preoperative therapy, then the recommendation is to continue with trastuzumab plus or minus pertuzumab to finish the 1 year of anti-HER2 therapy.
With regards to adjuvant endocrine therapy, this table here outlines what the recommendations are per consensus, NCCN consensus guidelines for breast cancer, and they're divided up by whether the patient is premenopausal at diagnosis versus postmenopausal at diagnosis. The category 1 recommendations are bolded and noted in the chart. And for premenopausal patients at diagnosis, the recommendation is either tamoxifen for 5 years, and if they've completed 5 years, considering an additional 5 years based on the Atlas and Adam trials, which I will discuss a little bit later in the webinar, or an aromatase inhibitor for 5 years with ovarian suppression or ablation, which is a more recent recommendation based on the SOFT and TEXT studies that I will also discuss a little bit further into the webinar. If someone is postmenopausal at diagnosis, the category 1 recommendations are listed here. There are several options based on a lot of data from the past. The big kind of point here is that postmenopausal patients are generally recommended aromatase inhibitor therapy for 5 years. But in some cases where they can't tolerate the aromatase inhibitor, perhaps tamoxifen could also be used. But the recommendation usually is to use an aromatase inhibitor in these patients. Next, I'm going to move into some of the data with adjuvant chemotherapy that has kind of led us to recent guideline recommendations or changes when it comes to adjuvant chemotherapy in our hormone receptor positive, HER2 negative, node negative patients. The TAILOR-X study was a prospective randomized multi-center trial that included hormone receptor positive, HER2 negative, node negative breast cancer patients. It was a very large study that divided patients up into 3 groups. One group had an Oncotype score of less than 10, which is a genomic test. The second group was had an Oncotype score of greater than or equal to 26, and the third group had an Oncotype score of 11 to 25. As you can see, the group that had a low Oncotype score was randomized to chemotherapy. The group that had a score greater than 26 was randomized to chemotherapy followed by endocrine therapy. And then the group that was in the middle, because historically we weren't quite sure what to do with patients who fell into this group, the aim was to find out if chemotherapy followed by endocrine therapy was superior to endocrine therapy alone, because standard of care in these patients, in most of these patients, depending on the score at that time, was chemotherapy followed by endocrine therapy. The primary endpoint of the TAILOR-X study was invasive disease-free survival, and secondary endpoints included distant recurrence-free survival as well as overall survival. This chart here shows the primary endpoints at 5 years and 9 years of invasive disease-free survival. And you'll see that in the patients who had a recurrence score on the far right of 11 to 25, there was not a huge difference in 5-year or 9-year survival in the patients who received endocrine therapy alone versus what they called chemoendocrine, which is chemotherapy followed by endocrine therapy, which is what led to recent changes in the NCCN guidelines and consensus guidelines in general on how to treat patients who have an Oncotype recurrence score of less than 25. There was a subgroup analysis done that I'd like to point out in patients who had a recurrence score of 16 to 25, but were under the age of 50. Those patients in this analysis were found to have a greater benefit from chemotherapy. And so the recommendation is from NCCN is to consider adjuvant chemotherapy in this group based on lower distant recurrence rates. And this is usually patients who fall into this group of under the age of 50 and with a score of 16 to 25. This usually ends up being a conversation between the oncologist and the patient about what their desires and wishes are based on the data that we do have. Another more recent change to adjuvant chemotherapy recommendations is based on the CREATE-X study, which has changed recommendations for patients who have hormone receptor negative, HER2 negative breast cancer with residual disease following neoadjuvant chemotherapy. And so I'm going to go through the CREATE-X data here briefly for you. This was a prospective randomized multi-center trial that included HER2 negative patients with HER2-negative breast cancer that had residual disease after preoperative chemotherapy. Patients in this study were randomized to capecitabine at 1,250 milligrams per meter squared twice daily on days 1 through 14, every 21 days, plus standard therapy. Or they were randomized to standard therapy alone. The primary endpoint here was disease-free survival, and secondary endpoint was overall survival. With regards to the primary endpoint of disease-free survival, at 3 years and at 5 years, disease-free survival was higher in patients who received capecitabine versus those who did not. In the ER/PR negative group, this difference was even more significant. And as a secondary endpoint, you'll see here too that overall survival was also different or better in the group that received capecitabine versus the group that did not. And again, here in the ER/PR negative group, the overall survival was higher in those patients who received capecitabine versus those who did not. Based on this study, the recommendation is to consider adjuvant capecitabine in patients who have hormone receptor negative, HER2 negative breast cancer with residual disease after neoadjuvant chemotherapy. A couple of things that I do want to bring to your attention clinically is that to consider the dose. So in the study, they did use the FDA approved dose, which in clinical practice, we know oftentimes our patients aren't able to tolerate even in the metastatic setting. And so that is something to consider. Another thing too is the number of cycles. In the CREATE-X study, they did 6 or 8 cycles. So that is also something that would need to be considered in clinical practice. Now that we've talked about a study regarding a hormone receptor positive breast cancer that's HER2 negative, and their recommendations for adjuvant chemotherapy. And then the CREATE-X study is more focused on changes to triple negative or ER/PR HER2 negative breast cancer. I want to transition into adjuvant anti-HER2 therapies, specifically focusing on the monoclonal antibodies and antibody drug conjugate, atotreximab emtansine. So this timeline here is just a visual to show you kind of where we were and where we've come to now. So trastuzumab was approved by the FDA for use in the adjuvant setting for HER2 positive breast cancer in 2006. And then years later, in 2017, pertuzumab was approved by the FDA in the adjuvant setting for HER2 positive breast cancer. And then in 2019, atotreximab emtansine was approved by the FDA for use in the adjuvant setting for HER2 positive breast cancer for residual disease after neoadjuvant chemotherapy. And this was based on the Catherine trial, which I alluded to a little bit earlier. The Catherine study was a multi-center randomized open label phase 3 trial that included HER2 positive non-metastatic breast cancer patients with residual disease after a taxane-based therapy plus trastuzumab. Taxane-based therapy was defined as at least 16 weeks of a preoperative regimen containing greater than or equal to 9 weeks of taxane and trastuzumab-based therapy. These patients were then randomized to receive atotreximab emtansine, or TDM1, every 3 weeks for 14 cycles, or trastuzumab alone every 3 weeks for 14 cycles. The primary endpoint here was invasive disease-free survival, and at 3 years, TDM1, the patients who received TDM1 had a higher invasive disease-free survival at 88.3% versus those who received trastuzumab, and this was statistically significant. The secondary endpoints were recurrence-free survival and overall survival, and the recurrence-free survival was reported here at 89.7% with TDM1 versus trastuzumab. Those who received trastuzumab having an 83% recurrence-free survival. Overall survival was not reported at the time of publication of the Catherine study. One of the biggest things to consider with using just trastuzumab alone versus using an antibody drug conjugate like adotrastuzumab emtansine is the safety profile difference. And so they did look at this in the Catherine study, and I did want to point out that that only about 70% of patients who received TDM1 actually completed all 14 cycles, versus with trastuzumab, 81% of patients completed all 14 cycles. Dose reductions were required in some patients who received TDM1. About 10% had a one dose level reduction, and about 4% had a second dose level reduction. 133 patients were reported to have discontinued the TDM1 early, and of these, 71 of them switched to trastuzumab. And the most common reasons for discontinuation were lab abnormalities, including decreased platelets, changes in liver function tests, specifically AST, ALT, and total bilirubin, as well as neuropathy. And a small percentage of patients discontinued therapy due to decreased ejection fraction. And so I've listed the adverse events, the grade 3 and 4 adverse events that were reported in Catherine here. And as you can see, the most common grade 3 or 4 event was thrombocytopenia in the TDM1 arm, and then peripheral sensory neuropathy, as well as radiation-induced toxicity, were also higher in this group, and hypertension was also slightly higher in this group. Before I move into some adjuvant endocrine data, I do want to point out that adjuvant neratinib has also recently, in recent years, been FDA approved for treatment of high-risk breast cancer that is HER2 positive, and more details on that study, which is the ExteNet study, can be found in the breast cancer content outline. I'm going to talk about a couple of the studies that led to the changes in the last few years in recommendations for adjuvant endocrine therapy. Several years ago, the recommendation was more straightforward. If a patient was premenopausal, they got tamoxifen for 5 years as their adjuvant endocrine therapy. If somebody was postmenopausal at time of diagnosis, they received an aromatase inhibitor, or switch therapy between tamoxifen and an aromatase inhibitor, as a previous table showed. But with some more recent data, those recommendations have changed, and so I'm going to go through a couple of those studies now. One of the first studies I'm going to go through is the SOFT study. This was a study that was done in over 3,000 patients who were premenopausal who had ER positive or PR positive breast cancer. These patients were randomized to receive 5 years of exemestane, which is an aromatase inhibitor, plus ovarian suppression, or 5 years of tamoxifen plus ovarian suppression, or 5 years of tamoxifen alone. The primary endpoint here was disease-free survival, and the secondary endpoints are listed here for your reference as well. The results of the SOFT data of the SOFT study included a primary analysis of those patients who were just on tamoxifen alone versus tamoxifen plus ovarian suppression. And you can see the 5-year disease-free survival here was 84.7% in the tamoxifen alone group versus 86.6% in the tamoxifen plus ovarian suppression group. And this difference was not found to be significant. What I'd like to point out, though, is in patients who are younger than 35 years of age, the number of patients there is included, 350 patients participated, and about 230 patients were included in the primary analysis, is that the 5-year disease-free survival was much higher in the exemestane plus ovarian suppression group, and even in the tamoxifen plus ovarian suppression group as compared to the tamoxifen alone group. When we think about toxicities when it comes to aromatase inhibitor therapy plus ovarian suppression in young women, a lot of what came out after the study was, well, what were the side effects? And so I've listed the toxicities that are greater than or equal to grade 3 here, and just to compare the tamoxifen versus tamoxifen and ovarian suppression. And 24% of patients in the tamoxifen alone arm had grade 3 toxicity versus 31%. And they were a little bit different among the group, which is understandable considering ovarian suppression can add on to the menopausal type of symptoms. And then specifically, the musculoskeletal insomnia, depression, and glucose intolerance, as well as hot flashes. And so those are listed here for your reference. The next study is the TEXT study that was eventually, whose results were eventually combined with the SOFT study, and I'll talk about that in a second. This study randomized a little over 2,600 women with ER positive, PR positive breast cancer to either receive just 5 years of exemestane plus ovarian suppression compared to 5 years of tamoxifen plus ovarian suppression. And when we look at how these were combined, they took the data from both of these studies and combined this to analyze the results of combining these two studies. And so the 5-year disease-free survival and overall survival is listed here. Disease-free survival was found to be statistically significant. And recently there was an 8-year update that showed disease-free survival at 8 years when ovarian suppression was added to tamoxifen was 83.2% versus with disease-free survival with an aromatase inhibitor with ovarian suppression was 85.9% at 8 years. And then overall survival was in the low 90s percentile, and not much difference between all 3 groups, but there was a statistically significant difference between patients who received tamoxifen alone and tamoxifen plus ovarian suppression with regards to overall survival. So with this data, the NCCN guidelines were updated to include ovarian suppression plus an aromatase inhibitor as a category 1 recommendation for adjuvant endocrine therapy in a premenopausal woman. I've included the adverse events that were grade 3 or higher here as well. The biggest, most common side effects in both of the arms were hot flashes, and those were comparable between the 2 arms. What was a little bit different was the risk of thrombosis or embolism, which was higher in the tamoxifen plus ovarian suppression arm, which makes sense with tamoxifen. And then musculoskeletal symptoms we know usually are associated with aromatase inhibitor use, and so those were higher in the exemestane plus ovarian suppression group. Other side effects that clinically were of concern too when these studies came out was osteoporosis. When since you're using ovarian suppression in a young woman with an aromatase inhibitor, which already has the risk of osteoporosis. But in this study, you can see here that there wasn't much of a difference between the two arms. The risk of fractures were higher though. And other grade 3 or higher adverse events are listed here for your reference. As I mentioned earlier, historically, the recommendation for tamoxifen has been to use it in premenopausal women for a duration of 5 years. In recent years, however, there has been more data to suggest that there may be more benefit to using tamoxifen for 10 years total. And so one of the studies that looked at this was the ATLAS study, which included almost 13,000 patients with early stage breast cancer. And they were randomized after 5 years of tamoxifen to either stop tamoxifen and be done with therapy, or to continue to complete 10 years of tamoxifen daily. The study only reported the outcomes of the patients who had ER positive disease reported. So there were patients in this study who actually didn't have ER positive disease, but the side effects were reported of all the women regardless of ER status. So the endpoints are on the far left-hand side, which included risk of recurrence, breast cancer mortality, and overall mortality. And as you can see here, 10 years of tamoxifen reduced the risk of recurrence, breast cancer mortality, and overall mortality. And what was also noted in this study was that even past year 10, there was still a long-lasting benefit of having taken the tamoxifen for those 10 years, even though they weren't taking them past year 10. And so that's what that last bullet point is with regards to risk of recurrence at years 5 through 14. Again, toxicities are a concern with this drug, just like any other drug. And so with tamoxifen, some of the main things we worry about are risk of endometrial cancer with long-term use. Also, we worry about thromboembolic events. And so those were seen at significantly higher rates with longer duration of therapy, as well as ischemic heart disease in this study. And as I mentioned before, this study also confirmed the benefit of tamoxifen even after treatment ends. And so back in an earlier slide where tamoxifen is still considered a possible treatment option for premenopausal women with ER-PR positive breast cancer, the consideration can be made at 5 years to possibly continue for 10. And there was a second study, which was the ADAM study, which continued to kind of confirm this benefit. So this included almost 7,000 women with ER positive or ER untested breast cancer. They were also randomized to stop tamoxifen at 10 years or to continue tamoxifen to complete 10 years of therapy. The ADAM study found that there was a significant reduction in breast cancer recurrence that was time dependent in patients who took 10 years of tamoxifen. There was also a reduction in breast cancer mortality, and there was a reduction in overall mortality, but this was found to be non-significant. And again, this reiterated the concern for toxicity. There were more cases of endometrial cancer in patients who received 10 years of tamoxifen versus those who received 5. But the rates of VTE were not reported in this study. And like I said earlier, based on the ATLAS and ADAM trials, the guideline recommendations were updated to include the possibility of adding an additional 5 years of tamoxifen in premenopausal patients, especially in those patients who have a high risk of recurrence. of course, should be balanced with patient tolerance to therapy as well. Those were kind of the highlights of some major changes in treatment in the early stage and adjuvant setting for breast cancer. And so now I'll move into metastatic breast cancer and provide an overview and then some of the newer data that has come out with regards to newer therapies for metastatic breast cancer. So this slide here includes a workup that is recommended for patients who have metastatic breast cancer or are suspected to have metastatic breast cancer, and that would include lab tests that are listed here. Other CBC and LFTs are standard tests that we do, but then depending on what treatment you may be planning or what their other comorbidities are, you may also get other lab tests like serum creatinine and PT-INR. Imaging is listed here as well. That's usually full imaging and sometimes based on symptoms. And CT chest is usually the most commonly used imaging, or CT chest and then abdomen and pelvis depending on symptoms. PET CT is discouraged by NCCN guidelines unless recommended staging is equivocal, and then an MRI of brain is usually dependent on symptoms. A big thing here is that biopsy should always be done of a suspected recurrence. It gives us a lot of information, including proof of recurrence, the histology, as well as the biomarker status. So is it ERPR, HER2 positive or negative? And in some cases, this could be different from their primary tumor. And so biopsying the suspected area is extremely important. When we look at metastatic breast cancer, we think about it as a local regional recurrence versus looking at it as a distant recurrence. When somebody has a local regional recurrence, there's a possibility that it could still be treated with a curative intent, depending on the previous treatment that they had and on the timing of when this recurrence happens. When someone has a distant recurrence, in most cases, this is no longer considered curable. Depending on the response to therapy and subtype of breast cancer that they have, patients may be able to be maintained long-term on some sort of therapy. And again, the goal here becomes more palliation and life prolongation versus cure. When we think about treating someone with metastatic breast cancer, another thing we should look at is whether or not there are bone metastases present. When there are bone metastases present, in addition to systemic anti-cancer therapy, we also want to add on bone-modifying therapy to prevent skeletal-related events. So examples of this include denosumab, zoledronic acid, and pamidronate. And then we need to determine what their systemic treatment will be based on their ERPR or HER2 status, as well as their symptoms at time of diagnosis, which I'll talk to you on the next slide about. If the patient does not have any bone metastases, the next step would be to determine systemic treatment based on biomarker status, like I said before. Generally speaking, someone with metastatic breast cancer should be evaluated as having either a visceral crisis, which means that they're having lots of symptoms and they have disease all throughout the body, versus those who are not in a visceral crisis. Someone who is in a visceral crisis is recommended to have chemotherapy considered first line, and that's continued until progression or toxicity. And depending on whether or not the cancer is hormone receptor positive or negative, if they do not have visceral or not having a visceral crisis, depending on timing of endocrine therapy, the recommendations are different. So again, we look at menopausal status when we're determining therapy. And we also look at whether or not they've had endocrine therapy in the year prior. And so if they're hormone receptor positive, then this algorithm applies more to them. And if they're hormone receptor negative, then systemic chemotherapy remains the only option, whether or not they're HER2 positive or negative.
When it comes to treating metastatic breast cancer, there are several factors we have to consider before thinking about or recommending treatment for these patients. One of the things to consider is hormone receptor positivity or negativity, as well as HER2 positivity or negativity, which will help guide potential treatment options for these patients. In the setting of hormone receptor positive, HER2 negative metastatic breast cancer, endocrine therapy tends to be the option of choice, especially in the first few lines of therapy. However, the NCCN guidelines do recommend that after less than or equal to 3 lines of sequential endocrine therapy with no benefit, to consider chemotherapy. So this table here actually lists options for endocrine therapy, and as you can see, there are several. In clinical practice, CDK4/6 inhibitors in combination with an aromatase inhibitor or fulvestrant tend to be first-line treatment for most of our patients. In those who may have a PIK3CA mutated tumor, alpelisib can also be an option in the second line or greater setting in combination with fulvestrant. Then that leaves us with some of the drugs that we've had for several years and that we continue to use as options for patients who have hormone receptor positive, HER2 negative metastatic breast cancer. Their regimens and drugs that are recommended or preferred per the NCCN are in bold, and the ones that have an asterisk next to them have a Category 1 recommendation per the NCCN guidelines. For patients who have hormone receptor positive, HER2 positive metastatic breast cancer, the options for systemic therapy are listed in this table per the NCCN. The preferred regimens are in bold, and the Category 1 recommendations per the NCCN include an asterisk next to them. So the preferred regimens are, especially in the first-line setting, are pertuzumab plus trastuzumab plus docetaxel based on the Cleopatra study. And then also this combination of pertuzumab and trastuzumab with paclitaxel is also listed as a preferred regimen. Other options have increased over the last few years with regards to options for systemic therapy for HER2 positive metastatic breast cancer, and that includes BAM, trastuzumab, deruxtecan, and XKI as one of our newer agents in our arsenal of drugs that we have for HER2 positive metastatic breast cancer. And so that's been very exciting for us in that setting. And then lastly, we have other chemotherapy options for metastatic breast cancer. In this case, single agent therapy is preferred in most cases. In some cases, we may need to use combination chemotherapy to get a more rapid response, especially in a patient who may be symptomatic from their disease. And in that case, we may combine some of these agents in order to get that response. But in most cases, we do end up using single agent therapy. The preferred regimens are in bold per the NCCN guidelines, and they're listed here for your reference. And as you can see, we have several different agents that can be used to treat metastatic breast cancer. And so we're very fortunate in that regard.
The next few slides, I'm going to go through some of the data that has been recently published in the last few years regarding some of the drugs that I've just mentioned here in these tables. So I'll start with SOLAR-1, which was a study done in hormone receptor positive, HER2 negative breast cancer that was advanced. And these patients were further divided up into whether or not they had a PIK3CA mutation versus not. And those patients received fulvestrant 500 milligrams intramuscularly, plus alpelisib 300 milligrams PO daily, or placebo in both groups. The primary endpoint was progression-free survival in the SOLAR-1 study. Progression-free survival was significantly higher in those patients who had a PIK3CA mutated breast cancer who received alpelisib, and it was 11 months versus 5.6 months in those patients. And so it is due to the SOLAR-1 study that alpelisib was FDA approved in this setting of metastatic breast cancer that's hormone receptor positive and PIK3CA mutated. And this is in combination with fulvestrant based on these data. What is unique about alpelisib compared to many of the drugs we've historically used for metastatic breast cancer is that its toxicity profile is a little bit different. The most common toxicities were hyperglycemia, diarrhea, nausea, decreased appetite, and rash. And so there are recommendations for using an antihistamine to prevent rash. There's a possibility that metformin at minimum may be needed to be used for hyperglycemia. And then also the monitoring is much more strict than maybe we're used to with some of these drugs. And so this drug is a little bit different in that sense. The most common grade 3 and 4 toxicities with alpelisib are listed here, and those also include diarrhea, rash, and hyperglycemia. The next two studies are on our PARP inhibitors. So the Olympiad study is what I'll start with. This included adult patients with HER2 negative, ER/PR positive or negative metastatic breast cancer with a germline BRCA mutation. And they were randomized to olaparib, 300 milligrams twice a day, or standard of care chemotherapy, which I have listed at the bottom left for you what standard of care chemotherapy was considered. The primary endpoint here was progression-free survival. And progression-free survival in patients who received olaparib was 7 months compared to 4.2 months, and this was statistically significant. And I have the secondary endpoints here listed for your reference as well. The EMBRACA study is also a study that was done with a PARP inhibitor, talazoparib. And this also included patients with HER2 negative, ER/PR positive or negative, locally advanced or metastatic breast cancer with a germline BRCA mutation. And they received talazoparib 1 milligram daily with or without food or physician's choice. And I also have outlined that at the bottom left for you. Progression-free survival in patients who received talazoparib also was 8.6 months, which was 3 months higher than the group that received physician's choice, and this was statistically significant. The secondary endpoints are also listed here for your reference. One of the common questions that comes up clinically is, well, what's the difference between these two drugs? The FDA approved both of these drugs for use in this setting with BRCA mutated metastatic breast cancer that's HER2 negative and ER/PR positive or negative. But what is the toxicity difference? So this chart, I've outlined the toxicity, all grades of both of the drugs. And you can see here that talazoparib that did cause more anemia as well as neutropenia. Thrombocytopenia wasn't reported for olaparib, but talazoparib does cause thrombocytopenia. Fatigue was also higher looking at both of these drugs, whereas nausea is higher with olaparib and may require oral pre-medication for some patients. Vomiting was similar, and the rest of these side effects are also either similar or not reported for olaparib. As far as grade 3/4 toxicities, you'll see here that talazoparib did cause significant anemia that was grade 3 or 4, as well as neutropenia and thrombocytopenia. And so it is important to monitor, do the appropriate monitoring for these drugs because the hematologic toxicities can be significant. Lastly, we have the Impassion 130 trial, which introduced an FDA-approved drug for breast cancer that was that was immunotherapy. And so this was an international randomized double-blind placebo-controlled phase 3 trial that included adult patients with metastatic or unresectable locally advanced triple-negative breast cancer. And those patients were randomized to receive nab-paclitaxel weekly on days 1, 8, and 15, plus atezolizumab 840 milligrams IV on days 1 and 15. And then the other group was to receive just nab-paclitaxel alone plus placebo. The primary endpoint here was progression-free survival and overall survival. And as you can see here, the addition of atezolizumab to nab-paclitaxel increased progression-free survival by about 2 months compared to nab-paclitaxel alone. And then even further, they looked into the group of patients who had PD-L1 positive breast cancer. And in that subgroup, the progression-free survival was also higher, statistically significantly higher than in the nab-paclitaxel plus placebo alone group. Overall survival was also higher, however, not statistically significant. And then the secondary endpoints are also listed here for you. Toxicity was only reported the only toxicities that were reported were those that differ by greater than or equal to 5% between the two groups. And so I do want to point that out here. But since we know that many of the side effects from immunotherapy don't necessarily cross over with the toxicities of nab-paclitaxel, we can kind of see that some of these are similar. So alopecia was similar. Nausea was a little bit higher in patients who received atezolizumab. Neutropenia was also a little bit higher, as well as pyrexia. Hypothyroidism was higher, which could be attributed to the atezolizumab and its the effects of immunotherapy. Grade 3 and 4 toxicities are listed here as well, and they only reported those toxicities that differed by 2% or more between those groups. And so peripheral neuropathy actually was much higher in the group that received atezolizumab plus nab-paclitaxel, which is interesting. And based on the Impassion study, the FDA did approve atezolizumab in combination with nab-paclitaxel to be used in patients with ER/PR HER2 negative breast cancer in the metastatic setting. And I've summarized the recommendations here in a table for you. So for the germline BRCA mutated HER2 negative, olaparib or talazoparib can be used. If someone has ER/PR HER2 negative or PD-L1 positive, plus PD-L1 positive breast cancer, based on the Impassion trial, atezolizumab plus albumin-bound paclitaxel is an option. And then there is also the option of using carboplatin or cisplatin in patients who do have a germline BRCA1/2 mutation. To conclude, I do just want to kind of summarize that patients often progress through several lines of therapy throughout their course of treatment. And with breast cancer, we are fortunate to have many different drugs at our disposal. And so oftentimes we'll see patients go through 5 and 6 lines of therapy before we are sometimes have to say that there are no more options. Risks and benefits should be weighed at the time of progression. Every time there is progression, there should be a risk-benefit analysis there and a discussion with the patient. Treatment options do depend on the presence of visceral metastases and patient-specific risk factors. That includes patient desires, whether or not they want to continue treatment, what toxicities do they already have from previous treatments, how quickly do they need a disease response, those types of things. There are more therapies now that are available based on molecular and genetic targets, and I went over a few of those, the alpelisib, the PARP inhibitors, the atezolizumab. We also have had in the last few months new drugs approved by the FDA, FAM, trastuzumab, deruxtecan, NXKI is one of those that can be used for HER2-positive metastatic breast cancer when a patient has gone through 2 lines or more of anti-HER2 therapy in a metastatic setting. Tucatinib, which is an oral therapy that is used in combination with capecitabine and trastuzumab and can be used after 1 or more lines of anti-HER2 therapy in the metastatic setting. And then lastly, we have sacituzumab govitecan, which is specifically recommended in patients who have triple-negative breast cancer after 2 or more lines of therapy in the metastatic setting. And so those are recent additions to our arsenal when it comes to treatment of metastatic breast cancer. With regards to adjuvant therapy, I just want to highlight again that the changes in recommendations for chemotherapy in the ER-positive, HER2-negative breast cancer population has changed recently based on the Taylor-X data. And then in the HER2-positive patient population, adjuvant therapy now includes adotrastuzumab emtansine or TDM1 if patients do have residual disease after neoadjuvant therapy. And like I talked about in the last few slides, in the metastatic setting, we have had so many new therapies that are based on molecular targets or genetic mutations. And so there are several options. And we also are doing more mutational analyses given these newer options. I thank you for your attention today. Thank you so much for listening.